Hello. Thanks everybody for coming, and we'll just get underway with the afternoon session. So, my name is Kofi Anie. Some of you know me, but those who don't, I'm a psychologist working with sickle cell thalassemia patients, London Northwest University Healthcare NHS Trust. But I'm also the deputy clinical lead for our West London HCC, working closely with Mark Layton that you met this morning. So we're going to have a very interesting afternoon session. I'm going to kick off by talking about sickle cell disease from a social and cultural perspective. And it's trying to explore the intersection of culture, society, and healthcare. So just to remind ourselves, social cultural factors in sickle cell disease. Basically, we know that the majority of the patients that we have in the UK are from African, Caribbean, and Mediterranean descent. We also have patients from Middle Eastern and Asian sort of origins as well. But when we talk about social cultural factors, I think cultural beliefs play a big role. And simply because there's a lot of misinformation about sickle cell disease that can affect treatment-seeking behavior, obviously from a psychological perspective as well as a medical nursing sort of aspects. This is quite important. Social stigma is a big issue, although sometimes we don't look at it from that perspective explicitly. And also, if we look beyond physical health, we've had a sort of a feel of some of the psychosocial impacts that affects patients because of societal attitudes towards affected individuals and families. So just to start off, when we talk about sickle cell, we talk about pain because the majority of people in the field look at pain in relation to sickle cell as a hallmark kind of symptom. But the description of the sickle cell pain in a lot of African countries, for example, identifies with the culture, but also in terms of how people see sickle cell. So in Ghana, where I come from, the people who speak a certain language called Twi, they refer to sickle cell as ahuntutuo. And it's basically a description of how the pain affects people. So in terms of ahuntutuo, is basically something like body pinching or body biting. And certainly in clinic just yesterday, there was a young patient, there's a pediatric clinic, and he came with his father, and we just trying to find out how much they know about sickle cell, because sort of they've just recently, come over from Ghana to this country. This is about a couple of years that they've come to the country. I decided that I would use the local terminology so that I could get a good description and good understanding, and obviously Dad was able to explain this quite a bit, because he described it as something that when he was growing up, so Dad has sickle himself, and his son also has sickle, but when he was growing up, that sort of description of the pain and the crisis that he used to have. And he actually said he had grown out of sickle cell, which is not true. He has less frequent crises, but he was saying that, this ahuntutuo, when he was young, it was a big thing, but now it's really not a big deal anymore. But I suggested to him as well that he needs to get his GP to refer him to clinic, because even though he's not having a lot of crisis, he needs to be followed up for obvious reasons. But when we look at sickle cell, I think one of the big things that we have are societal attitudes. So this is a very good example that I picked up. So we all know that in recent times, NHS Blood and Transplant have been doing these donor campaigns with an emphasis of sickle cell, because it's easy for, let's say, Black communities, minority ethnic communities to identify the fact that if I donate blood, it would go to somebody with sickle cell. But this was something like I don't know whether it was a tweet or something on social media, and this is a typical way in which attitudes are portrayed. So when NHSBT is trying to say that you can save someone's life by donating blood, somebody's given the response, if we deport all Blacks, this will stop being an issue. So this is sort of the impact societal attitudes can have on individuals. We also know that in terms of health services, pain is a big thing. And why is it that patients who have frequent hospital admissions, there is mistrust on the pain severity? And if you look at pain from the point of view of health professionals versus patients, pain levels are always underestimated. And studies have been done. One particular study that was done in the States, in Philadelphia, years ago, just showed that if you have health professionals, nurses, doctors rating the pain that patient experiences and the patient's ratings themselves, there's always discordance. There is a difference. We as health professionals lower the pain severity just because that is our perception of how sickle cell patients must feel the pain. Unfortunately, we also see some patients as being opioid dependent or addicts, whereby we know from a psychological and a medical point of view that we can actually define dependence and we can also define addiction. And some work was done years ago in East London, whereby they looked at sickle cell patients broadly in terms of addiction versus the general population. And there was no difference. I think it was about 2 to 3% in the general population in terms of opioid addiction, and it was no different among sickle cell patients. So that is the problem. Another way of looking at it, so we've had problems around emergency departments. Everybody knows about this No One's Listening report. But there was also a secondary report that was produced with some work that was funded by the NHS Health and Race Observatory. This is probably just about 2 years ago. So if you look at it, patients, these two reports highlight the same thing. Patients experience due to limited sickle cell knowledge, but I think it's not only the knowledge, the attitudes, as well as we know, discrimination highlights some of this. And even earlier on, there was some work that was done, data collected from a PICA survey, the survey that we are kind of utilizing in terms of finding out patient feedback from their experiences, also highlights that. But for me, this is the big one. This is a study done in the States. And when you talk about emergency physicians, these are basically emergency department doctors. And what is said in this study is basically that, if you use the term sickler, And the person who did this work, he's called Jeff Glassberg. Actually, we had the opportunity of him coming to London and doing some work with us some years ago whilst he was training. So I know him personally. So what he did in this work was just basically a survey looking at the attitudes of doctors in the ED department by using the term sickler that we tend to use quite readily, and showing that it was associated with negative attitudes. But the big thing is that, and on quote, not seeing sickle cell patients as people, and hence, inevitably delivering low quality of care. So this is a big example of how societal attitudes feeds into health services and giving us this kind of problem in terms of these two reports on the work that has been done in the UK as well. And then moving on to education and employment, I think the last speaker before lunch, Nana, gave a very good example of how this feeds into the system. But I just want to highlight a couple of areas. Because sickle cell pain, and in more recent times, fatigue, which if we didn't started looking more deeply into it, may not realize that it affects patients as much as pain does. And that is basically that those who have frequent pain episodes and extreme fatigue, and that can lead to absenteeism, both in terms of school and work. And the false impression that it creates in terms of people being lazy. So in children, this is a big issue, and we are always trying to work with schools in terms of school care plans and so on. But in adults, the example that Nana gave, the case example that she gave, highlights a lot of these issues. That when somebody has problems, we just see them probably as being lazy. But sometimes it's a combination of the pain issues that they have as well as fatigue. And also, if you look at it, sickle cell does not fall under disability in schools. So, and it doesn't fall under special educational needs. There's no criteria that you'd get to support this. Some years ago, we had a chance with Floella Benjamin, who is in House of Lords. They were trying to change this, and she had really done a lot of work with children in her earlier years. So if you look back, she had done a lot of stuff with kids around sickle cell, and she wanted to push something through that would get sickle cell into the new sort of bill that would identify them as having a disability or having special educational needs. This was not possible. But so basically we are having to make, case by case, on the case-by-case basis, having to try and support or get the right requirements. What we have is something that is called an educational and healthcare plan, for which they will get the right support if we are able to identify them within that category in any school, but it's almost impossible. I mean, there are kids with sickle cell that have had a stroke, and yet they would never be considered automatically to have that sort of educational needs kind of support. And then going to adults, obviously, we've had the example, but also in terms of the requirements, not being able to meet that. And in some cases, and I think COVID might have even helped a bit, but in some cases, some of the adults that we try to get support in terms of working from home, some of the employers would say nothing to that. And then moving on to cultural and religious beliefs. So talking to that gentleman and his son yesterday in clinic, it just highlighted this kind of issue, that a lot of our patients, parents, families, I would call recent migrants, and that could go 10, 20 years. So in terms of their culture and their beliefs, it hasn't gone anywhere. in terms of the origins. So if you look at this in terms of what are some of the big cultural and religious factors. So there are superstitious beliefs, and there are, practices. In Africa, we would say some of the big areas are things like witchcraft or reincarnation. So if you look at the Igbo people in Nigeria, for example, they believe that everybody is reincarnated. The term is Ugbanje, right? But what they put as malevolent Ugbanje is basically that, if you have young children, so in Africa, unfortunately, the majority of children under the age of 5 would die with sickle cell disease, not knowing that they had sickle cell disease. Why? Because malaria is highly prevalent, and malaria is a big issue in terms of affecting young children. But if you have sickle cell, obviously, and you are undiagnosed, there are no prevention measures in place, so you'd probably die before the age of 5 with sickle cell disease. So this perception that children are reincarnated, everybody is reincarnated, but children with sickle cell are reincarnated over and over again to torment their parents. That's the malevolent Ugbanje. That's basically that you need to be able to identify these children. So sometimes they'll put a scar or something, hoping that if the child is reborn, they can identify that. And in addition to some of these practices, you'd have, traditional healers, and you'd have, prayers from religious leaders. But this sometimes happens here, because I've heard stories about parents, for example, a child being sick, having fever, and instead of coming straight to the hospital, they would rather go to the church, the minister, the mosque, the imam, somebody to do that religious or cultural intervention, and then wasting time before they come in. And sometimes this affects treatments in terms of prevention, beliefs about, penicillin prophylaxis, and all this kind of stuff before they would do the right intervention. And that really does affect health-seeking behavior, as I wanted to highlight from the beginning. And then you have family dynamics, another big issue. I'm sure some of us have experiences. So because women are the child bearers, women get pregnant, they give birth to children, they would be blamed for sickle cell. The man or the father of the child would leave because they don't believe that they have sickle cell in the family. So the genetics is all mixed up, and issues of accusations of non-paternity as well. We see it here all the time. There are, other issues, for example, at the antenatal level. Why is it that in certain families we have 1, 2, 3, 4 children with sickle cell? Because at the antenatal level, in this country, we do newborn and antenatal screening. It's linked together. Why is it that people refuse to do any intervention at the antenatal level? We know from the data that the majority of mothers or prospective couples will not accept antenatal screening from the point of view of woman being pregnant, screen for sickle cell, bring your partner. They wouldn't bring the partner. One of my trainees years ago did a study. Why is it that women with sickle cell trait and their reproductive decision making is very confusing? Why? Because they just want to be mothers. They would rather pray that at the end of the day, they would have a child without sickle cell disease. If you offer prenatal diagnosis, that's at one level. They wouldn't accept it. If you offer prenatal diagnosis and they accept it, a very small proportion, they wouldn't do anything about it, which is fine. They would wait for the child, and they'll tell you, they wait for the child to be born, and they'll tell you things like, we hope and pray that they'll be fine. And again, yesterday, typically in clinic, a young couple, they've had a baby with sickle cell, expecting another one. And they are not going to do anything about it. We just want to wait. And we'll pray and we hope everything will be okay. The child wouldn't have sickle cell disease. So these are some of the issues that, affect the health-seeking behavior or the acceptance of interventions that are helpful. And then we talk about social stigma. But stigma, basically, by definition, is being ostracized or treated badly because of some characteristic. So individuals have little or no control. And, it varies from different groups and in different time periods. But basically, the origin is that it dates back to the Greeks. And there was this publication by a person called Goffman, Notes of the Management of a Spoiled Identity. So back in the days, the Greeks would either make a mark or a cut, a tattoo, something, in the skin of criminals, slaves, traitors, to identify them as tainted or immoral people that should be avoided. And so this is how it affects individuals. Guilt, humiliation, disgrace, prejudice, shunned, embarrassed, isolated, ashamed, lonely, disapproved, different, devalued, worry, sadness. And this is not an inclusive list. So if we do the same thing with people with sickle cell, this is how they feel. And so how come we are surprised when they are going for employment, they wouldn't disclose? When they're doing something in society, they wouldn't disclose. Within families, the dynamics, because they don't want the extended family or other people to know that they've got sickle. I'm sure we all have experiences of this, those that are working directly with patients. So this is a problem. But if I put it all together, then you have sickle cell disease on one hand, which is a genetic disorder. And then you have the stigma based on cultural beliefs, social exclusion, and it is a burden. And obviously pain being the hallmark, health barriers, and everything combined. This you can find in my recent presentation at the ASH conference, but it's been published in the educational book as well. I think it might be available free online, I'm not sure. But anyway, how can we address this? Just the fundamentals. Talking about sickle cell from the point of view of the general public and society is about more public awareness, improving knowledge and understanding, and then dispelling the myths. But we have the issue of attitudes as well. But from the patients' and families' point of view, it's about empowerment and advocacy. And healthcare professionals, obviously the education and training at all disciplines and at all levels. And I think that is important simply because one of our consultants, she's not even a hematologist or whatever, but I asked her, because she was a young consultant at that time, I just asked her, where do we get attitudes that are negative about sickle cell patients from? Because a lot of times we have trainee doctors or even trainee nurses just coming to the hospitals, and they already have a negative attitude towards patients. So where does it come from? And she said, in training, in medical school, the amount of training we have is not sufficient, but also it is kind of prejudiced against the sickle cell patients to start in terms of, how you manage pain versus how you manage pain in a cancer patient and so on. So I think, apart from the knowledge, there's an attitudinal problem that we need to resolve. So in summary, I would say sickle cell requires a holistic approach, but the importance of integrating cultural understanding with medical advances as well. But also trying to address the social cultural barriers to improve patient outcomes. And I think the important thing is that sometimes we may not necessarily identify some of these social and cultural issues. And obviously, the joint efforts to create awareness and support individuals and families affected with sickle cell disease is quite important. Thank you. I think we are running a little bit late with time, but maybe a couple of quick questions or comments.
These things that you've mentioned. So in terms of the raising awareness, there's so many advocates out there. They use their personal page to talk about their stories, but the No One's Listening report has been out since 2021. Trusts are not really being held to account to actually look at those recommendations and implement those changes. So it's just, what are the practical kind of tips that you can give us? I know we all do training in our different trusts, but it'd be good to know what are some of the practical things
I think in terms of training of health professionals, one of the easiest things, and some of us do it probably a bit anyway, but maybe not as frequent, is trying to incorporate the patients in the training sessions that we do with staff. Because sometimes just little things like, when patients are sick, people, let's say healthcare professionals, look at them differently. But when they are well, they actually see that, this person is, just a person like everybody else and has sickle cell. So I remember we once had this guy, young guy, who was very angry with himself, with his sickle cell, and sometimes he would come to ED and smash things up. But the funny thing is that when he was well, he would actually come and apologize and bring something to the nurses. So I would always say to them that, look, this guy has a lot of issues, but as you can see, when he's well, he's a completely different person. So the interesting thing is that even though he had a red card in ED, which is basically trying to ban him because of inappropriate behavior, the ward where he was admitted, they were always ready to accept him. And if you have a red card and you have a crisis, you are not supposed to be refused treatment. But he has a red card in ED, he gets his ED treatment and he comes to the ward and then he's fine. So it's those kind of things that I think can help. But also, we probably need to focus a bit more on empowering patients so that maybe they could be better advocates when they are within the hospital setting as opposed to being outside. So those are some of the things that I think we can incorporate. Yeah.
Just referring to the important point you made about trust being held accountable. So are there conversations nationally about linking the No One's Listening report to CQC inspections?
Not really. I think there has been sort of efforts to try and get trusts to meet the requirements of the report. But the one problem that we have is that if there are no penalties, nothing really changes. I mean, we try and do our best as those that are on the side of the patient, as well as, being health professionals. But if there are no penalties for the trust, and so we can have these reports, we can try and implement, But if there are no penalties at a higher level, then it's very challenging.
I've got a question. So as you were talking, Kofi, you mentioned that there could be cultural or religious factors in that patient's health. I want to ask the clinicians in this room, how was that brought up during intake when you're seeing a new patient? Are you asking those questions about religious background? How are you documenting that? Is that standardized? And then how are you responding or following up, if at all?
Well, I mean, maybe somebody can also answer the question, but I think some of us just take an approach whereby we try to explore as much as we can, and trying to identify, especially when there are certain behaviors or there are, for example, refusal to, let's say, accept treatments or, that kind of stuff, trying to find out what some of the bases are, and sometimes you are able to accept that. You see, I don't mind if people still come, because it still happens with the adults as well as children, that sometimes people would come to the clinics, they would accept everything that you give to them, but they might not go beyond a certain level. And at the same time, it's difficult, but when you probe, you'd find out that some of these patients have religious backgrounds which will more or less say the same thing, that, I know one day I would test negative for sickle. A lot of adult patients say that. And probably it doesn't really matter, as long as they would accept what is right in terms of the treatment that we are offering them, or the support that we are offering them. And I think that is quite important.
Sorry, I'm a paediatrician, and to answer that question, in clinic I explore, the usual question I first ask is, do you know anyone else who's had this condition? And that is a really good question to get you into kind of backgrounds and the understanding of disease and what it is, but it often takes a really long time and a relationship with a family, and I mean over years sometimes before you really get to the nub of things sometimes, and it kind of further to that, there's a really interesting intersection, and it's a difficult part of work where you've got a clash between parental beliefs, cultural beliefs about disease, and then the kind of, as a paediatrician, advocating for the child from the scientific perspective, and where that goes into safeguarding is really complicated, because we work really hard to try and understand those cultural differences and to try and address them from many different angles. But it's a really difficult intersection of actually everything that we've been discussing from this morning as well, about equality, diversity and inclusion, and respecting where that's come from. Yeah. But at the same time trying to advocate for the child. And it's a different angle when you're as a paediatrician, because you've kind of got this three-point relationship between the child, the parents, and you as the clinician. But I think it's the importance of a long-term, multidisciplinary, I sit here with my entire MDT, relationship with the families. Yeah. And that's really critical in building trust.
Just, I think we'll just take one more and then...
Yeah. I'll just link in with what my colleague just said.
I will allow you.
As a general paediatrician as well, that's some of the challenges we find. So in answering your question, I think when you got somebody in front of you and then you're exploring reasons to not adhere to your recommendations, then you start exploring the backgrounds and their beliefs, and then you find these things out. And I imagine it's very different between adult medicine and peds medicine, because you can have a person, you understand their beliefs are different to yours, and you have a good working relationship, but they make choices you don't agree with, but the choices only affect them. So you can just choose to still have that doctor-patient relationship. And, as you're speaking, I'm thinking, of a particular child, and we now have a really good relationship with these parents. She's really involved in sickle cell education, but we fundamentally disagree with her management of her child. And we've even brought it up in conversation that it's him who's experiencing these painful crises. And yes, we have issues, you have safeguarding procedures you put in place, but does that achieve what you want? You know, you want the boy to remain with his loving family. I guess I'm saying this, I don't know the answer, but I guess as paediatricians was expressing within this forum that we find that aspect, you know, quite challenging.
Yeah. Okay, just, sorry.
Sorry, and thank you. I'll make it really, really quick. So I'm just wondering, how much weight does the clinicians have in terms of having that education of being able to empower the parents and the actual patient themselves when it comes to things like who do they go to get assessed for an EHIC plan for education? Because I don't think parents always, or the patient themselves, always join the dots that their absence, their constant absence in education is affecting their mental health or just their ability to even think they can continue their course and stuff like that. And in colleges and schools, they don't really understand sickle cell, as it were. So there's that massive gap between the, you know, how do you do it? Can a clinician refer in? Do they even know who and where?
So that is why it's important that, let's say from a clinician's perspective, we get kind of like a holistic picture as to what is happening. So for example, you might want to pick up on the fact that, you know, let's say loss of schooling. I mean, there are certain questions that, you know, you can ask, probing, how are they doing in school? I think in terms of probably using that kind of a multidisciplinary approach, because we know that every child is supposed to have a school care plan. And sometimes it's just worth asking, how are they, you know, utilizing the care plan? Finding out, you know, frequency, admissions, versus loss of schooling time. Sometimes they are not coming into hospital, but they are not going to school because they are managing the pain at home. So it's up to us to probe as much as we can so that we can see where the gaps in support are. But when it comes to schools, I can tell you it's very challenging. And I think it's more of a numbers game, because in any area where you have a high concentration of, let's say, high concentration of sickle cell patients, basically, you don't necessarily have high numbers in each individual school. I can estimate over the years that maybe 2 at a time, on average, 1 or 2 at a time, even though they might have seen other patients during the course of, you know, so it's like a constant thing of trying to remind, you know, parents, trying to probe and, you know, try and see what the schools can do. But it's mostly up to us. Thank you.